Welcome back, everybody. This is our second segment of 7 Minutes for Seniors. I am Chris with Modified Independence here with Brandi Renfro from Move Mobile Therapy. This is like a co-op working space kind of thing in Nocatee.
Yes, yes,
Yeah.
it is. Mhm.
Okay. And we're in the main conference room. We're sitting at this huge table, the two of us in really low chairs.
Mhm.
This is awesome. I feel like a kid in like middle school or whatever.
Yeah, because it's so
Yeah.
low, but the
The
table's high.
chairs. All right. So our second segment, we're going to talk a little bit more in depth about specifically what you do. So, how is it that you help seniors? What is it that you do that helps seniors?
So, one thing I really like about being a mobile physical therapist is that when I go in and I meet seniors in their home, I get to see how they function and what they do in their own environment. So, I'll go in and I'll do an evaluation and we'll see where's your pain, what kind of issues are you having, what's difficult for you to do. And then we use their environment and we make a plan for them to become more successful in doing those things that are difficult for them. And I find that working with people in their homes, it's so much easier to develop home exercise programs that they will continue to do that will benefit them for longer because we're already in the space that they're in every day. So I really enjoy working with people like that. And then it's one-on-one because you do not often get one-on-one PT if you go to a facility.
Right.
So I enjoy working with people
Now,
one-on-one.
did you ever work in home care under Med A?
Yes, I've done Med A and I've done outpatient clinics.
Right.
Hmm.
Okay.
Yep.
So, how would you say that patients are under Med B? Are they do you have a different mindset? Because even under Med A, it was like
Hmm.
the patients would probably more than 75% of the time would only exercise when the therapist was there.
I feel like that's an accurate assessment. More often than not, when people come to me for therapy, it's because they've reached out to me because I don't advertise
Mm-hmm.
other than social media. I have a few physicians that will send people to me occasionally, but the majority of people that come to me because they want to improve,
Mm-hmm.
they want to get better. Whereas when I was doing Med A, there were people that wanted to improve and get better, but I also came in a lot of times and, I would be told, you're here because my doctor told you had to come here,
Mm-hmm.
and I'm really not interested in this. So it's a mindset change when people contact you when they want to get better. They
Mm-hmm.
seem to get better.
Right. Yeah. I mean that's it, and that stands to reason because
Yeah.
right now the machinery is that somebody goes to the hospital for whatever reason, a fall, sickness, whatever, right?
Hmm.
And then the hospital is bound to discharge them to rehab to guarantee a good discharge home. And then once
Hmm.
they discharge them home, then they discharge them home with home health care.
Hmm.
Because the problem is that if you, as the patient, go back to the hospital for a fall or whatever the original reason you went to the hospital for was within 30 days of your initial hospitalization, then everybody down the line has to pay Medicare back.
Hmm.
So, in a case like that, like you're talking about, these aren't people that would typically be part of that machinery, or they would already have been passed through that machinery,
Hmm.
perhaps told that they're plateauing or that they can't do maintenance therapy
Hmm.
under Med A,
Hmm.
and instead you can come in and help them
Hmm.
to continue to make that progress.
Yeah, that's
Right?
exactly right. And so there are occasions where I'll have people who go and they have a surgery or they've been into the hospital, but they've been patients of mine before. So when they go to rehab and they say, "Oh, let's get you set up with home health," I've had people say, "Oh, we already have PT. We're ready.
Oh,
Here's
nice,
the
nice,
card, and we're
yeah,
ready to go there." So that's nice in that sense.
because they can articulate that to you.
Right, right.
Right,
Because it's a patient's choice.
right.
Patients can have the choice to go to whatever provider they want at any time they
Yeah,
want.
people don't
And a lot of
realize
people
that.
don't know that.
Yeah,
Right.
yeah. The printout of home health companies is in alphabetical order for a reason.
Hmm.
The licenses are sold
Hmm.
based on provider numbers, and the people with the A's get a lot of referrals, and the
Hmm.
people with the Z's don't get very many because typically
Hmm.
the people have to flip the list over.
Hmm.
So, has anybody from the healthcare machinery contacted you about concerns if your patient? I mean, have any of your patients been rehospitalized to where they were worried? The hospital was worried about having to pay some of that money back.
Not not people who were recently discharged from the hospital.
Okay.
If so, it was someone who had gone through therapy, had been discharged, and then had another issue later.
And then, but they're not looking. So the rehab is not looking for you to do medication reconciliation
Right.
or any of
No.
those things.
No.
Right.
None of that. Although I do look at those because
Right.
that's my due diligence as a health provider. You know, I
Right.
want to see what my people are on. That way I can see how it will affect them physically.
Right.
But no, the requirements are different, and I feel like it's much less bureaucratic
Mhm.
because I can go in and see the person and not have to complete 400 pages of paperwork.
Yes.
I still have a lot of
Right.
paperwork,
Yeah.
but it's things that are relevant to what we're there for.
Right. Yeah. It's kind of like getting a degree at a liberal arts school versus getting a focused degree or specific training on like welding or something like
Right.
that. Right. You're not going to be taking a literature class if you're going to be a welder.
Right.
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 So, and that's why I do prefer to refer to Med B, because then I know that the issues that are present to the patient are going to be addressed.
Mm-hmm.
It's not the fox in the henhouse situation where the doctor writes an order to eval and treat, and then magically the 16 visits that Medicare is going to pay for in 60 days are already filled up with people in their agenda, instead of the patient's agenda, which is to work on X, Y, and Z. So they really get the opportunity to do that.
Right. One thing I also like is when I evaluate somebody, we talk about who their primary physician is or who their surgeon is, depending on what the issue is. And then I write my evaluation and send it, and I wait for it to come back. I'm monitoring all of that. And if there's any medical issue, or if there's any issue with, say, my plan of care that the physician has, they know exactly how to contact me, and I know exactly how to contact them. And in Med A situations, the therapist doesn't see any of that.
Right. Yeah. Yeah. I noticed that a lot of times. It was, just a blanket order, go do whatever you can do. So,
Yep.
All right. Do you have any ideal clients? Who's your ideal client?
My ideal client is an older adult who has mobility issues, who wants to get better.
Period. If that sounds like somebody you are or somebody you're related to, reach out to her. All of her contact information is coming up in 3, 2, 1.